It's now my pleasure to introduce this morning's moderator, Dr. Michael Dittola. Dr. Detola is a 1988 graduate of the University of Pacific School of Dentistry and was awarded his fellowship in the AGD in 1995. Dr. Detola was in private practice for 15 years before becoming Director of Clinical Education for Glidewell Laboratories, giving him an intimate knowledge of American dentists' crown and bridge habits. From 2006 to 2009, he led the clinical team that developed and brought Bruxer solid zirconia to market. In 2011, he received the Most Effective Dentist Educator Award in a nationwide survey of dentists. And in 2015, he became the Director of Clinical Affairs for Sirona. In 2017, he was named the Vice President of Clinical Affairs for Aegis Communications. Dr. Detola has given over 1,000 lectures to dentists worldwide, and his online videos have been viewed more than 15 million times by dentists all over the world. It's my pleasure to warmly welcome today's moderator, Dr. Michael Dittola.
Well, David, thank you for that. I appreciate that gracious introduction. And as we get started today, just a couple of things I wanted to share. My dad was a dentist, and one of the reasons I became a dentist was because he used to take the entire month of August off, and he would rent a house in Kauai that we would stay in for the entire month. And after graduating from dental school, I always wondered what it would be like to have a month off. And now I guess we all kind of know what it would feel like to have a month off, even though this is clearly not a vacation. But it does feel like a chance to get a fresh start, or perhaps at least change the way we go about certain things. For the first time since most of us started our practices, we have the time and the space to redefine who we are in our professional careers. So if you were always too busy to learn to surgically place implants, or sharpen up your endo skills, or learn to do minimally invasive periosurgery, this sure feels like the time to do it. And with practices just starting to reopen in the last couple of days, it's most likely going to take several weeks or more for schedules to be full again. What a great time to learn new endo or perio techniques, or to commit yourself to something you always meant to do, like placing rubber dams on way more patients. This is as fresh of a start as we are ever going to get. And an author named Chuck Blakeman wrote a book I love called Making Money is Killing Your Practice. And it's about the struggles of trying to move your practice from survival to success to significance. And the first chapter is called How We Got on the Treadmill and Why We Can't Get Off. Well, as you've no doubt noticed, the treadmill has been unplugged. So maybe you are 10 or 20 or 30 years into your dental career. You now have the experience and the wisdom to visualize what you want your practice to look like 10 years from now. And for the foreseeable future, we'll be seeing fewer patients, and it's a great opportunity to provide dentistry, more dentistry to them that we previously may have ignored or referred. And within these anxious and uncertain times in dentistry, there's a real opportunity to build something that felt impossible to do before. So let's get started with our two speakers today. Dr. Gordon Christensen is the founder and chief executive officer of Practical Clinical Courses, the CEO and co-founder of Clinicians Report Foundation, and a practicing prosthodontist in Provo, Utah. Gordon and Rella are the co-founders of the nonprofit Clinicians Report Foundation, which used to be known as CRA. And since 1976, they've conducted research in all areas of dentistry and published the findings to the profession in the well-known Clinicians Report. I used to be a project director for the newsletter. I still refer to the newsletter all the time. Do yourself a favor, subscribe to the newsletter, especially now that they'll be reviewing PPE devices and other COVID-19 things. And I feel sure there's going to be a few scams out there, so we'll want some good information. Gordon, thank you for joining us this morning.
My pleasure. This is a virtual world now. I wish I could see all your eyeballs, but your eyeballs might even be asleep right now. You're in your pajamas, you're eating your breakfast. We've been doing everything virtual for, well, 3 months now, hundreds of programs to hundreds of thousands of dentists. So it is a way to communicate. Please be candid with your questions. We'll see if we can answer them.
Yes, thank you. And if you are asleep, rest assured you will still receive your CE credit, but you will get more out of it if you're awake and actually listening. Our second presenter is Dr. Sam Lau. He's a past president of the American Academy of Periodontology. He's a current officer for the Academy of Laser Dentistry. He provides periodontists, dentists, and dental hygienists with the tools for successfully managing the periodontal patient. He was also selected Dentist of the Year by the Florida Dental Association, for whom he's also a past president. He's a past ADA trustee and a proud recipient of the, wouldn't you know it, Gordon Christensen Lecture Recognition Award. Sam, thank you so much for being with us.
Well, thanks, Mike, and thanks, Gordon. I do believe that for our audience, you're in for a real treat, a very candid conversation and I would reinforce, Mike, what you suggested. This actually, if you look at the times of the Great Recession, we went back to school, we learned things. Our patients are going to be asking us to do more for them and not referring out. So this is a great conversation that we're going to have for the next few minutes.
Well, thank you for being here, Sam. Really appreciate it. So we have a prosthodontist and a periodontist. So this is a great combination of two specialties. And Gordon, I want to start with you because I did what I often do, and I went back and I watched one of your PCC videos. This one happened to be on peri-implantitis. And it was talking about it affecting 45% of implants at 9 years after placement. And it's not just the US, Sweden, Switzerland, Italy all have similar numbers. And I remember coming up in the day where implant companies were quoting a 95% success rate. Is this the reality of what you see yourself? And I know you talk to tens of thousands of dentists every year. What are you seeing with the incidence of peri-implantitis?
Mike, 37 years ago, I was amazed to see the titanium alloy. Well, in that point, they were pure titanium implants come on. I had been doing vitreous carbon blades, subperiosteals, all kinds of implant placements, and they would fail fairly soon. Vitreous carbon, even in weeks. So as the titanium ones came on, I thought, we finally have done it. And I learned how to do that. I was the first one in this state to place implants. And over the years, I've done, of course, about a dozen brand names, and there are now 500 brand names, believe it or not. And little by little, I would see some failures. I'm sure Sam would agree. We all have failures, but one thing we don't remember is class 2 composites only last 5 to 7 years if they're big, 15 years if they're little. Everything we do, crowns last roughly, if they're even done well, about 20 years. We didn't expect implants to do that. We thought these were going to just be around forever. And then about 10 years, 15 years into it, we started to see it wasn't the implant failing as much. It was the superstructure. It was the crown. It was the metal supported resin restorations on top of the crown, on top of the implants. So I started to see, well, I started telling patients as we did the diagnostic activity, 1 out of 20 of these is going to fail. And I don't know which one it is. 1 out of 20 of these we're going to put in your mouth will fail. I would say that when we did the diagnostic, I would say it when we placed it, and I would say it when we restored it. And I was pretty right. And if I had done a wonderful job, sometimes they failed. If I had done a crummy job, sometimes they worked. So then I started looking at the reasons for peri-implantitis. And a shorter answer to your question is, yes, we're seeing peri-implantitis, and several have jumped on and classified it into 4 classifications. Much of that should be done by hygienists. So the data that's coming from Gothenburg that you quoted is correct in my opinion.
Good. Well, good to hear that. We're going to talk about later on in the webinar ways of treating that. I just wanted to get a feel for the incidence of it. And around that, Sam, I'm wondering what you think or what you've read is the incidence of periodontitis in the U.S. And I just want to throw in my 2 cents, Sam, as a GP. At the University of the Pacific, where I went to dental school, we had 8 steps of oral diagnosis and treatment planning. And out of those 8 steps, step 4 was the perio one. And we actually used to refer to it as the perio penalty box, because you might have a great restorative case that you were excited about doing as a dental student. But if the patient had 1 4-millimeter pocket on the distal lingual at tooth number 17, even though it was fully erupted and in occlusion, you went to the perio penalty box. So for a lot of GPs, at least starting off in school, it always felt like perio was this thing kind of holding us back. And so maybe that's why GPs tend not to view it with such a fine eye as you do. But I'm looking at the screen now. Explain to me what we see here. These are some good numbers.
Well, you're correct. Even though I'm a periodontist, I can wear Kevlar as far as knowing what dentists think about perio. In many areas, when you ask them, it was sort of like the purgatory that you went through. But we're going to turn this around and take a look at what I consider to be one of the major growth centers in a dental practice pre and post COVID-19. And if you look at this and you look at most dental conditions, I would challenge, if I was doing a business plan, I'd be looking at periodontics because, and this is CDC data, and what it really demonstrates is about 47% of folks over the age of 30 have, I'm not talking gingivitis, I'm talking about bone loss periodontitis. And I would ask our viewers to really look at the highest percentage, which is the moderate periodontitis. And what we're going to do is have a conversation about taking the general dentist through a journey as far as being able now to manage moderate periodontitis. I don't mean sending it back to the dental hygienist for some more SRP or periodontal recare, but actually doing what the patient needs in reducing pocket depths, increasing attachment levels, not taking anything away from the periodontist, because you still see there's 8.5% that the periodontist can do. But Gordon and I have had many conversations about this. I remember him writing an editorial in the Journal of American Dental Association. He got a few hits on that one. But the bottom line is, here's what he said. He said, you know, a patient generally just has sort of two things from us. One, you don't get it. And two, you get traditional flap and osseous surgery, which most folks probably do not want if they've ever seen it on YouTube. So as we go into that, from that area, we believe, and we can speak more about this, that patients want more minimally invasive procedures. They want to stay in your practice. They are more demanding, and Gordon has talked about this. Mike, you've talked about this. And they're actually really want to be with you. And coming out of this, that's the procedures that we think we can share with the audience today on where we need to be. And so now what we're seeing is this is not necessarily just what we're considering to be the standard of care in medicine, but now the standard of care in dentistry. So Mike, yes, there is definitely a need for these procedures as we take a look from this standpoint of new procedures going on.
And I know, Sam, you're going to share a study that's just about to come out with us later that compares minimally invasive perio surgery and conventional surgery. Gordon, I know on your DVD, you referenced some split mouth studies where conventional surgery was done on one side and minimally invasive surgery on the other side, and they got similar results, but with very different patient experiences. I want to know, Gordon, why should the dentist and the team have the skill sets to manage periodontal disease in their practice? I know in the past, dentists may say, well, I'm so busy with crown and bridge, I don't have time for anything. So, but it feels like an ethical thing to me. Like as GPs, there's no legitimate excuse for us not to be diagnosing and possibly treating mild to moderate periodontitis in our practice.
You are very correct, Mike. I often use this rather humorous analogy. We over-treat dental caries. That's the major disease that dentists treat. And we start out with a handpiece, not how to prevent it. Way back in my career, I was chairman of operative back in my puberty. And I knew very little about what caused caries. It was supposed to be strep mutans. Now, Dr. Rella Christensen, my wife of many years, has now shown by DNA analysis, she's a microbiologist, that strep mutans isn't even in 40% of the lesions. And all of us learned that was the major one. Even companies have been set up on it. So we overtreat caries, but we don't really think about the preventive orientation. We learn decent perio in most of the dental schools. We get out. Now, if I get a group of 300 or 400 or 500 people, I'll often ask, how many of you have done at least 10 perio flaps in the last year? I doubt if I'll get five hands that go up, literally. And one of the articles I had in the ADA journal was, why do general dentists shun perio? What's the third disease? Occlusion, and most dentists can't even spell that one. Therefore, we're really restorative dentistry mechanics. And it frustrates me. I've worked around periodontists my entire life. Robert Schallhorn, one of the guys in perio, I was with for 8 years as we started at the University of Colorado. Then subsequently, many periodontists, and I do quite a bit of perio myself. But the bottom line is, why is this shunned by general dentists? I think one of the reasons, and I'll be brief here, is it never heals totally. We just attenuate it, and that upsets a lot of dentists. They want a finite conclusion. They want to stick the crown on, glue it, kiss them off, and send them home. That's what they want to do. They don't want to have to labor on and on and on and on. I think that's a major psychological factor in why they don't want to do perio. But then also it's been surgery, and the patient's completed with the general perio surgery, and what? They have sensitive teeth. When they bite an apple, the teeth want to come out because they're mobile, and the occlusion's screwed up, and they think, why did I do that? I know I'm being too hard, Sam, but in the meantime, a lot of patients have that opinion of perio, and therefore dentists also have a negative one. We need easier techniques, and I know you're going to get to that in a minute. For years, I've emphasized conservative perio treatment, and I'm sure you're going to ask me about that eventually.
Well, it's interesting, Gordon, that there's your PhD in education coming in. That's really an interesting observation, that dentists like we're used to getting margins for the tooth and the restoration to come together, and we like things that appear to be precise, of course, until you use a microscope. But with perio, it's kind of ongoing and never kind of cured. So there could be a frustration from that. 40%, according to that map, Sam, you just showed, 40% of America has moderate to severe perio. That's 131 million Americans. And there's only 5,000 periodontists in the country. So even assuming they were spread evenly across the country based on population, that's 26,000 patients per periodontist. That's obviously not going to get it done. I feel like as general dentists, the general means we should do the general procedures in our office, and the specialist should do the special things. And I feel like that 8.5% of severe perio is the special thing. Is that, well, I can see now you put a slide up that looks like that you agree with that generalists do the general things, specialists do the special things, and the patient's going to get the best treatment.
Absolutely. This to me is an excellent visualization of what you and Gordon just mentioned. We call it swim lanes. If you look over on the immediate left, you'll see the dental hygienist, and there you see the 62% of gingivitis and early periodontitis. And I've read the surveys done by Gordon and the group. 98% of all perio and management of implants is done by a dental hygienist. And so if you look at that, here's our dental hygienist in swim lane 1, effectively managing non-surgical perio. And we'll talk a little bit now about, now that we're moving a little bit more towards manual instrumentation and somewhat away from ultrasonics, at least in the soft launch, where that might be with laser. And then in the center, we'll talk more and really emphasize more on that one as far as the dentist. And you mentioned the 40%, Mike. So here's our moderate periodontitis. And we're going to highly advocate that now you're going to be using D4260 codes. You're going to be doing periodontal surgery, but not the traditional flap-in osseous with sutures. It's going to be minimally invasive. That's what patients want. And you're absolutely correct, Mike. There's only 5,000 periodontists in the United States. I mean, if we just managed 8% of that, we'd be working 7 days a week for the next 50 years. So we're not trying to cut anyone out. So let me just run into this first group called the hygienist and where they may be. If you're listening, if you've been on the webinars, aerosol, is really at the height of what is occurring, especially in the hygiene operatory. And we can go back and forth on what generates the most aerosol, but we know one thing, dental hygienists are a little concerned about going back to the dental office. Part of that is the aerosols that are in their operatories. There's probably going to be more reliance on manual instrumentation. And with that, now's the time to seriously look at something called laser bacterial reduction. Because LBR, which is approved, FDA approved, including with Biolase and its Epic H laser. But when you think about it, there's 500 dental hygienists. And so I want to switch over just for a moment and also talk, please don't let those hygienists go. Bring those hygienists back. Reinforce with them that it is, if they do the appropriate PPE, HVE, and pre-procedural rinses, but notice the hygienists that use laser, they're generating $15,000 to $40,000 additional each year, and they're doing the right thing for the patient. So as I move towards the second swim lane, which we want to put some emphasis on today, that swim lane is moderate periodontitis. And if you look at dentists managing perio, especially moderate, you're improving patient care. You're not sending it back to the scaling and root planing, and to a certain degree in some offices, supervised neglect, but you're keeping revenue in-house. You're getting new patient referrals because those patients then hear from their colleagues. And to a certain degree, and I think both of you would agree, sometimes it's okay to say this. Sometimes I like technology because it sort of makes it fun again. So for the most part,
no backups for 48
so for the
days.
most part, you know, it is 3 swim lanes in which we're all going to benefit. So we're going to sort of take our conversation and sort of move it into that middle swim lane.
Gordon, since I graduated from dental school and started coming up to Provo and seeing you, I've heard you say over and over and over and over that GPs should develop their clinical skills and should start. The first thing I heard you talk about was GPs could start surgically placing implants, because the surgeons at the time were putting wherever the bone was and then leaving up to the GP in the lab to figure out how to get a tooth actually back in the arch again. I remember you saying in Europe and in other places, GPs did a lot more of the surgery themselves. Do you feel the same way about perio surgery, especially when Sam is coming up with a way that's not necessarily flap and osseous surgery? Do you feel this is within or the skill set of a GP, or they have the ability to learn this and do it comfortably in their offices?
Mike, I consider all of dentistry to be a specialty of medicine. By the way, we are the largest specialty of medicine. And in many countries, dentists get an MD before they get a dental degree. I speak in several of those countries, Spain, Austria, Italy. And what is perio? What is pros? In my opinion, they're a subspecialty. So for a dentist to not know something about perio, something about occlusion, something about implants, to me, makes them in a little microcosm where they are incapable of making a good treatment plan on anything. Yes, I feel very strongly that, well, the image that Sam just showed, that there are certain procedures that are well within the realm of a general dentist, if they want to. But speaking psychologically now for a minute, dentists fall into the same categories as typical general physicians. You have the bloody types and you have the non-bloody types, and you can pretty well identify them in all parts of medicine. We're the same way. Many dentists, well, I have 2 sons who are dentists. One's a prosthodontist, one's a general dentist. One hates blood and won't do it. The other one will do everything from brain surgery to circumcision. You know, as a general dentist, I'm kidding, of course. But the bottom line is, what a difference. But there's a group of dentists out there who want to do implants, yes, and are doing implants very well. And there's a group of dentists who will do apicoectomies. They will do biopsies. Just yesterday I was on a webinar where we were talking about, why aren't we doing biopsies? We should be doing that. So for the bloody group of dentists who aren't worried about a little drip of blood on themselves, yes, they should be doing these things routinely at a level of excellence If they feel uncomfortable, here's a phrase I use. If I would not do a procedure on me that I'm contemplating doing it on somebody else, don't do that procedure. That's what Sam's for.
Yeah, and Sam, it sounds like Gordon's come up with another indication, an off-label one, a use for the Waterlase, a different soft tissue surgery that he suggested there. But to Gordon's point, I mean, to try to be ignorant of perio and occlusion, and then try to figure out peri-implantitis, it seems crazy if you're not going to take those two things, because occlusion obviously has something to do with it, as does perio. So if dentists are going to follow Gordon's suggestion, and even the ones who are probably non-bloody dentists, as Gordon refers to them, I feel like you're going to show us more of a non-bloody technique than maybe flap and osseous surgery. So let's get right to it and show me the technique that you're proposing for minimally invasive perio surgery. Actually, Sam, I can't hear you. I don't know.
Got it. Sorry about that. As we look at that from that standpoint, and we've talked about the swim lanes and the dentist and the better way to manage perio. This is actually a mini flap, or sometimes even through the sulcus. It's an all tissue laser. And not only does the clinical results similar to flap and osseous, but probably one of the things that's really highlighted in past studies and present studies is what we call patient-related outcomes. And when patient-related outcomes are important, what we're basically seeing, and this has been verified by probably we consider to be the #1 landmark study ever done comparing to a certain degree traditional periodontal surgery with what we call Biolase repair, which is a minimally invasive procedure. And so what you get out of this is #1, for those of us who are interested in the clinical effects, absolutely, they're almost equivalent. But let's face it, every now and then when we do traditional flap and osseous surgery, people get up the next day and don't really feel like going to work. And the most important part of this particular study that was soon to be published is it demonstrates that these patients are taking less discomfort medication, they have less swelling, less bruising. And by the way, when you look at the procedures by quadrant and time, there's a good 25 to 30% less time in doing this procedure, getting the exact same results as you are with traditional flap and osseous surgery. And so we believe that a dentist wants a cookbook. Yes, we are, and thank you, Gordon. I've always felt that we are oral physicians. Why we chop the mouth off, I don't really understand it in the healthcare world. But what dentists want, because they've been through the physiology, the biochemistry, what they want, however, is this step-by-step, Sam, tell me how to do it, that I'm gonna get those equivalent results and my patients are gonna love me. And so what I've done is sort of created a cascade for you. You're starting out, in each one of these steps is validated by studies, validated by wound healing, validated by what we call new attachment. And so as you see this, but I want to re-emphasize something about lasers. A laser is not a laser is not a laser. You cannot do what I'm suggesting with a diode laser. You need to do this with an erbium laser, only because an erbium laser is the laser that also not does just soft tissue, but my friends, we've got to do hard tissue here. We've got to decorticate the bone. We've got to do some osseous surgery. We've got to remove the smear layer so we can get some kind of attachment. And as you see as we go through this, but I don't want us to forget something that you see in the middle slide. We are going to do root preparation to the best of our ability. No, so with this, if I take a look, and Mike, if I just show a case study of a dentist, this is Russ Morrow with Heartland. Russ had never really used a laser. We went in, showed him those steps. He was using, by the way, the laser you see down there, which is an all-tissue laser. And in 4 months, he generated $50,000 of additional revenue, value-added revenue that he had not had before. So he had a 25% production increase, 22% collection increase, new procedures, especially minimally invasive perio and osseous crown lengthening. So what I think is that dentists need this. They need to be managing moderate. We have the solution for them in a fairly simple, straightforward, not coloring book, but close. And then when you do that, your patients get the best quality of care of maintaining their teeth, so they may not get those implants. You're somewhat happy doing it, but it's financially beneficial for you.
Thank you, Sam. And yeah, when that $50,000 in revenue, I mean, sometimes when you hear things like that, you know, a dentist might say, well, was that treatment really necessary? But I think we're saying, yeah, yes, this is stuff that was just going to slip through. This isn't like an optional cosmetic service. This is perio that either was just getting pushed into the hygiene department without a proper diagnosis and was being done, as a friend of mine used to call, a prophy in a pool of blood. Or maybe in the most extreme cases, it was getting referred out and patients were going for flap and osseous surgery. So it really is a result of just diagnosing more properly and being more honest with patients and caring enough to care about perio and to diagnose it. Gordon, anytime I've been up at your office, you have a lot of technology in your office. Of course, every company wants you to review everything they're coming out with. You know, anytime we look at technology, there's always a price tag associated with it. It's, you know, whether it's an investment in the technology or the training that's going to happen to teach you to learn this. How do you feel like the average dentist, where do you stand on the average dentist investing in technology like this, and how they're going to get an ROI and value-added benefits they can pass on to their patients?
Excellent question, Mike. Recently, we did an evaluation and a survey of 47 different technologies, believe it or not. And we had the dentists rate how valuable they thought the technology was, the specific ones. And they had to have used the technology before they could rate it. And it was an extremely interesting thing. Then subsequently, we got involved with the evaluation of the most significant technologies. Right on the top, I'm sure you would expect it to be cone beam. Those who use cone beam say, where have I been? What have I been doing? Have I been perforating the bone when I'm placing an implant? I have no idea where I am. I've been on cone beam now 21 years. Among those that were considered valuable by the respondents was laser, and not particularly diode laser, which frankly is hardly a laser, because you put some black thing on the end of the fiber optic bundle and turn it into a big mother electric surgeon, making a cut 3/4 of a millimeter diameter. And frankly, with some of the lasers, such as Biolase or Solia or Photona, you can get down to a very, very small cut, and you're actually cutting with the light. I don't know how diode has had so much popularity, other than you can buy one for somewhere from $3,000 to $14,000. So what I'm saying is, yes, those who use it not only find value in these more sophisticated lasers, but they also find their revenue increases. Soli has done a major study on that, and it relates to all lasers. The patient is excited by the word laser because it's great in ophthalmology, so it ought to be good on teeth. There's a psychological shock there for them when they find out, yeah, it does work, but the revenue increases. I'm hopeful that dentists are honest with what they're doing, particularly the restorative ones, and not cutting a hole in every black spot on the tooth. But the technologies that have value are easily identified, not only for the patient, for the dentist, but also because they increase revenue.
And then, so the struggle to recognize and diagnose periodontal disease in the practice, I think one of the beneficial aspects, Sam, of purchasing the technology is now you have this reminder to remind you to look for and diagnose, and maybe you put systems in place, or maybe you give your hygienist a helper so they can, go a little more deeply into recall patients who haven't had a full mouth probing or whatever. But I think the technology, one of the reasons why you produce more is because you've got this thing you invested in, you committed to, okay, I want to diagnose and do more perio. And now you have this device there, which kind of it keeps you honest, and it makes you kind of follow through. And instead of just saying out loud at a staff meeting once, let's diagnose more perio, you've really made a commitment to it, and you've got some skin in the game, it feels like, at this point. Speaking of peri-implantitis, Sam, I want to hear you talk about the laser and what can be done with peri-implantitis. You start to see threads appearing and there's some bone loss, and especially for dentists who maybe just got started placing their own implants, I'm sure this is a terrifying thing when the patient comes in with an anterior tooth and they smile and you see those first threads. So talk to me a little bit about specifically how lasers can be used for peri-implantitis, if you would.
Sure. From the standpoint of, let me get over here to my desktop to do some sharing with you. Just one moment as I get over there to it. Here we go. And the fact that Gordon had mentioned, about, let me just get over here to that. The incidence of implantitis is truly substantial. From the standpoint of implantitis, there are 2.7 million implants placed in 2017, 6% increase a year. But interesting enough, we always use these terms like 5%, 10%, 5%, 10%. But a study done, and this has been parallel with other studies, we're looking almost at 1 out of 5 implants are lost, and after 2 years. So if you look at that numbers, over 500,000 implants per year in USA need attention to implantitis, mucositis. But I think our point is that probably the most effective, I'm not even going to say most effective laser, but the most effective system in managing implantitis right now, the studies are beginning to show that it's an erbium laser. And you can see, these are just typical radiographs of before and after. And so now we have a way of managing implantitis. I would also like to get Gordon's opinion on this, because you know how we used to say we monitored, watched periodontitis? My concern is we're doing the same thing with implantitis. We're seeing we're seeing some inflammation. We're seeing the first resorption around a thread. And then what we're doing is we're watching and waiting to see if it goes to the next thread. My philosophy is, why wouldn't you want to take a procedure similar to what we just did with periodontitis, get in and stop it as soon as you can with something called perio repair implant procedures, which is very straightforward and very similar to what we just discussed.
Well, thank you, Sam. That's interesting. And I know that, Gordon, I've been up to your practice many times, and I don't think I've ever seen a dentist who delegates as much as you do, whether it's your dental assistants or your hygienist. You practice what you preach, and you've got DVDs on this, and you've always talked about delegate everything that legally you're allowed to do by your state act, and then another 10%. No, you didn't say that. You just said everything that you're legally allowed to do. And actually, one of the questions that we got from a hygienist, it's more of a comment. It's her frustration with in her dental practice where she works, that the dentist not diagnosing enough periodontal disease, and she kind of goes crazy over in hygiene. So talk to me a little about delegation within the hygiene department. And it sounds like you use your hygienist for treatment of the peri-implantitis as well. So I'd like to hear about that too.
Yes, okay. Recently, John Suzuki, a well-known periodontist, and I made a video on peri-implantitis and the treatment of peri-implantitis. And I'll take a minute to tell you about it. By the way, while I'm on that, if this excites you, go to this website, P like in Paul, C like in Charlie, PCC.org. dental.com. And because of this COVID fracas we're in, everything you get on that website is now 20% reduced. So this video goes through the steps of peri-implantitis. And what we're seeing is the initial couple of steps, the initial peri-implantitis, and the moderate one can be done very well with a laser without making a flap. And now the more advanced part of moderate peri-implantitis, a flap sometimes is necessary. And as you get into the severe peri-implantitis, then a flap is probably necessary. But that bottom beginning area of peri-implantitis is highly facilitated by cleaning that pocket out and blasting the tartar off the threads. That would be one thread, maybe two threads would be initial. And then you get into moderate, you're up to 3, 4, 5 threads. Now some of those can be treated that way, but think how the patient feels. We're going to cut your gum wide open and we're going to scrape around down in there. It's not good psychology. We're going to put this little light down below the gum tissue and we're going to take the debris off the implant. That sounds a lot better to the patient. So that involves hygienists. It involves assistants who are well educated. Let's go back to your initial question. How do you get dentists involved with delegating? Psychologically, it is really hard. Only I can do that. Only I can do that. The heck, that's right. I have taught people how to do occlusal splints, how to do sleep appliances. And after they've done 6 or 8, they can do them better than I, because all I can do is remember how I did it. But they're doing it. So those, whoever asked that question, pick something simple first and have the assistant become very competent with it, like making temporaries. A lot of dentists won't even let the assistant do a temporary. So start simple, and soon the dentist begins to agree that, wow, they're doing a better job than I did. I certainly see that myself. But there are a lot of things out there that the staff can do as well as or better than the dentist. And in that realm is treatment of peri-implantitis.
Yeah, and it's interesting, you know, we kind of think as dentists sometimes, oh, I know morphology or anatomy better than my assistant or my hygienist, but at one point you didn't. And then at one point you learned and you got better. And I'll never forget being at Glidewell, and somebody was taking a tour, and she actually taught local anesthesia at a hygiene school up in Seattle. And I asked her, what injections do you teach the hygienist? And one of them was the Gow gates. And I said, oh, I never got a chance to learn that when I was in dental school. And somebody else on the tour was a dentist who had been graduated 2 years from a California dental school. She hadn't learned the Gow gates either. And so I asked this instructor, will you teach me how to do it? And she said, yes. And I asked the other dentist, will you let me do it on you? And she said, yes. So we sat down and videotaped it, and it's got 600,000 views. So a dentist might say, well, hygienists can't give as good of injections as I can, or as profound blocks or whatever. But it's clear that if they learn how and learn in hygiene school, that they can do that. They can help diagnose, they can help do this treatment, and it just frees up the dentist to do the big high dollar things that we're supposed to be doing. Sam, as a periodontist, we know what GP hygiene departments look like and what they tend to do on a daily basis. Tell me a little bit about the differences, if any, between the hygiene department and a periodontal practice and the activities that they do. And are they involved with peri-implantitis, and how involved with they must be more involved, I would think, with perio than a hygiene department in a GP's office. But tell me a little bit about what gets delegated in a specialist office.
Absolutely. We hygienists are highly valued in a periodontal office. They are our bread and butter. They're the ones that keep us afloat as far as procedures. You know, we have always said that it is the periodontal recare that makes or breaks you in this business. It's not the procedure that I do. That's part of it. But a dental hygienist is an incredible value to us. I've always said, if you're a general practitioner and you're trying to decide what hygienist to hire and everything is equal except one hygienist has worked in a perio office, grab them, because that individual knows where we're going with this. Like Gordon said, when we see periomyositis, just like his hygienist, we don't say to the patient, brush a little bit harder. No, we have procedures that we do to implement right now and make that thing happen. It is possible. And Gordon, even with talking with the diet, if you don't initiate the tip, then you probably have minimal adverse events, and you probably are moving a little bit more towards this lactobacterial reduction. But I would agree with you, Gordon, this thing of initiating that tip, most dentists end up using this thing as an electrosurge because they haven't had the appropriate training and they don't understand the physics. But yes, if I had my way, hygienists in periodontal practices would be exactly like hygienists in dental practices and vice versa, because we are sharing the same patients. My hygienist is your hygienist and vice versa.
Yeah, and also to Gordon's point, he was talking about the diode laser. The thinnest tips I've seen are maybe 300, 400 microns. And just for crown and bridge, it's difficult to use troughing around a prep in the anterior because you're going to lose tissue height. You can be much more precise with an all tissue laser. I'm old enough that from going to Gordon's courses, I was on electrosurgery, long before diode lasers were available, and you forget how fast they are, if you start using a diode laser just to cut tissue. But it's very quick. But the diode laser is also nice because it is slower, and you can make, I feel, kind of less mistakes with it. Gordon, you mentioned PCC in the COVID-19 era. It doesn't look like we're getting out of this anytime soon, even though offices are reopening, and I'm not sure if Utah is open again, but I feel like when I see patients, I saw a DSO, the North American Dental Group, who's got about 200 affiliated offices, and they did a survey of 1,300 of their patient base, and 71% of them said they were too concerned about COVID-19 to come back to the office for elective procedures, right now, as of today. So as we return to our offices in the midst of this, what are some of the things you think we can do? Because obviously we're going to probably have to be proactive with our patients and let them know what we're doing differently. And certainly that could include the incorporation of lasers as part of the treatment. But what do you think dentists should be doing to encourage people to come back in? Because we can all go back to work, but if the patients don't show up, this whole thing falls apart.
May I refer those of you who are watching this webinar to, this is one long word, and it's free stuff I've got there. Clinicians report. That's all one long word, no spots, no dots, no spaces. Cliniciansreport.org. Pull it up. You got the home page. Scroll down to the bottom of it, and you'll find complimentary information. And there are at least a half dozen things there that will gear you exactly into what we're saying at the present time. And you'll find contradictory statements with CDC, EPA, ADA. We're real world. I think you know that. We've been around 43 years. We say it like it is. So take a look at it like it is, not the way some potentate is telling you to do. We've got a lot of activity going in infection control that highly concerns me. The government dropped the ball back in the Reagan administration. They took out any federal observation of infection control products. It's been picked up by private agencies who contract with the company to do the research. You see a little flaw there? The wolf's loose in the chicken house. The bottom line is we've had products that don't even work. 4 out of 5 of the products we test don't work. 85% of the face masks right now coming from China don't work. I could go on. I already said how bad the air purifiers, so-called purifiers, are. Go to that website, cliniciansreport.org, pull up. You can spend the whole day looking at some of these things. Some of Rella's research is profoundly upsetting because we showed ethyl alcohol worked 25 years ago. Everybody dropped the ball, started putting Clorox on everything. Unbelievable. But to answer your question briefly, as we've been going 2 weeks now, as the patient comes to the building, we won't let him in. Out comes the front desk person with a face mask on and with gloves on. They do a temperature. If they're, I don't like the CDC's number there of 100.4, even if they're even 99, I'm concerned. And we'll let them in the office. They have a face mask on. They have gloves on. They're waltzed down to an operatory previously set up with barriers in it. The staff all has face masks and gloves on and wears them all day. What a hideous thing. And then the patient sits, we do whatever we're going to do. And again, they put their gloves on, their mask on. They do not touch the chairs in there. They do not talk to the receptionist. The reception goes outside, does the paperwork. So that's one thing that will slow down the fear of patients and especially hygienists. The biggest thing we're hearing on the circuit is hygienists are whining. They're whining, and they got the most ridiculous tool of all that Sam kind of gave us some way to get over it, and that is the ultrasonic scaler. We've edicted that they're not to use that, at least for this entry period. But I said it before, I'll say it again. I feel much more dangerous going in the grocery store with 90% no mask, no gloves, standing close together. The dental office is safe if you just use a ½ ounce of sense. By the way, Rella's video, if you go to pccdental.com, it's 24/07, it's 3 hours, and it'll shake you up.
It will, because she will very clearly tell you the one surface disinfectant that works. It's gonna make it real easy for you. There's basically only one that works.
Then I've got a course coming up. When is it? Saturday, again, pccdental.com, on 50 tips that will get you back into practice. 50
Yeah,
tips.
that's very good. And it's so funny because the idea of patients wearing masks and gloves and being met in the parking lot and bypassing the waiting room to go right to the operatory would have sounded insane 3 months ago. And it might, if you've been in dentistry 20 or 30 years, still feel insane today. But I think it's that kind of reaction, as weird as much as you might think it scares patients off, I think this is what is going to bring them back, that we're showing we're taking it seriously. Out of those 71% of patients that told the DSO they didn't want to come back, almost 40%, 39% said it was because they didn't trust the dentist, the office, to do the infection control properly. And that's because we're a profession that just wore, Gordon never has. He's always worn disposable gowns with elastic every time I've seen him, but most dentists have short sleeve scrubs on and a watch and one mask all day. So we haven't really taken it seriously before, but now we can catch it. And so we are. And so Sam, as Gordon mentioned, you mentioned ultrasonic scalers and the aerosols that it creates. Obviously the handpiece is going to create a lot of aerosol as well. We've been pretty much breathing that for the last 20, 30 years of our career through our masks that may or may not, probably didn't fit. But talk to me a little bit about the laser. You had mentioned earlier on that it creating less aerosol or using less water than a handpiece does. I'd like to hear your thoughts on that, because I think aerosol mitigation, and again, even if these things are just in appearance to what we're telling the patient so they feel safe enough to come back in, because as Gordon pointed out, the grocery store is more dangerous than the dental office. Even if it's just about appearances, I think we need to be proactive. So talk to me a little bit about aerosol reduction with using a laser.
Well, one of the added benefits to an erbium laser, and Biolase has just completed these studies, is if you do look at a traditional handpiece, you're looking at essentially 80% less water for a erbium laser, which does use water because it's where the photoacoustics comes from, versus a handpiece. If you do go on Vimeo, and we'll be able to show you where to find this, look at the videos. We also then looked at Waterlase versus a handpiece. You can see a substantial difference between using an erbium laser and doing a restoration and using today's high-speed handpiece in the amount of aerosol. And over here on the right, you'll, in a graduated cylinder, where I put some arrows, at the same exact time, you can
actually, Sam, I'm not, I don't think you're sharing your screen. I'm not seeing it. I'm still seeing. You and those beautiful white
Well,
flowers.
I will go back
Flowers.
and share. How about that?
Yes.
So,
Gordon
So,
claims he's read every book behind him, by the way. I asked him
yeah,
earlier. He's read
right.
every one of those books.
I recently thought, I looked at it and I thought, I should burn those. In 1 second, in one click, I can get more information out of some of those tomes that are.
Yeah, on your own website, exactly. Okay, go ahead, Sam. Sorry.
so again, here's an example with the less water, the less aerosol. Again, as I mentioned, from the audio standpoint, and if you go on Biolase website, you'll actually visualize the differences in the aerosol production. And again, I'm just relating to where the errors are. While we're on that, I would also mention that when we begin to take a look at lasers, we need to be looking at those programs with capital equipment that are truly allowing the practitioner to get in and involved with laser technology. This is just an example. Biolase calls this the Biolase Partnership Program. No payments in 2020. Again, get on the website. And also has a rebate of not only no payments till 2021, but also a rebate from that. And I would also mention, while I have the screen, is that we produced a couple of practice guides for you. If you're interested in what we discussed about LBR and laser-assisted periodontal therapy, yeah, my email is down at the bottom. I'll be more than happy to make sure that you get that practice guide for hygiene. And we just finished a practice guide for that second swim lane for the general practitioner who wants to do minimally invasive periodontal surgery. And those guides not only include just how to, but it also has billing guides, it has some marketing aspects. So if you would like, and I'm sure that Nathan managing the chat room, that he'll put my email address back up there for you, but we'll be more than happy. It's going to probably take till Monday before we can get it out to you. It'll be electronic. So you are able then to jumpstart and see where you want. If you're on this webinar and you already have an Epic Hygiene or you already have an I+ or an Express, please ask us for these guides, because we've put a lot of effort into these to make sure that you're using them correctly, but also in marketing for your patients.
Well, I think that's great that Biolase is doing that, Sam. I spent a couple of years at one of the chairside CAD/CAM companies, and there was no way we would ever let you have the unit without paying for it up front, because the first 20 crowns that you make are going to be the hardest ones you ever do, and you'd go, oh, take this back, I don't want it. So I can see confidence on your part that the ease of use doing these minimally invasive periodontal surgeries is going to be enough that they're not scared when they go in and try to use it for soft tissue and for osseous tissue as well. And I hosted one of these roundtables for laboratory owners a couple of weeks ago. And when I asked the labs what they were going to do differently, first of all, they were all hoping that we would all switch to digital impressions and stop sending them bloody chunks of polyvinyl and polyether with bloody cotton rolls still attached to them. So I said, okay, that's a fair point. But they also said that they realized they were going to probably have to give dentists terms, and that financial terms, and then they weren't going to be able to just demand to have the lab paid their lab bill paid all the time, because they realize that dentists have been out of work for a couple months, for one thing. And as we get back to work, the patients who are coming in, they may have been laid off as well. And if we're doing a $5,000, $6,000 case on a patient, they may be making payments as well. And so the one thing I heard about the labs was they want to get crowns back faster, but they realize they may have to have terms with the dentist. And so props to Biolase for realizing that a capital expenditure like that might seem counterintuitive to a dentist who's been out of work for a couple of months and seeing fewer patients. So props to them for, I guess you said it was free for all of the rest of 2020, and they actually get some rebates and can start using it and get that production like you showed in that Heartland slide. So that's good to hear. I think that's fantastic that they're willing to do that. All right, we have time for a couple of questions. This first one is for Gordon. This is from John in Mississippi. And Gordon, you kind of already answered this, but you probably have another way of saying it, or as dentists, we probably need to hear it again. And that is, if lasers are proven to have equal patient benefits, but yet less pain, why can't we seem to get more offices offering this to patients to help them?
Hard answer. It's a financially significant piece of machinery, and that upsets many dentists. And certainly at this time, when they have been working for a while, it's going to be a little bit more of a handicap. On the other hand, that can be spread out over a period of time with any one of the technologies. If I were to go through the 47, it takes a whole day, and some of them actually help finance with whatever the technology is. That's been one of the reasons. Well, you look at CEREC or Plan Make a Fit or any one of them, and that's only 10% of the whole marketplace. It's been around 36 or 7 years. So the cost is probably one of the challenges. Right. Other challenges are laser way back. It's been my first encounter with laser was in the early 60s. It's been around a long time, and therefore they're wondering, well, if it's been around that long, why isn't it more used? It's not more used now than it was a few years ago, but it's growing fast, and I see this lack of invasiveness being a salvage for laser. I believe I'll talk with Sam about that. It will help salvage the laser image, to be able to go in and in a non-invasive way, blast the junk off those threads. I've gone in, laid a flap, used a burr, cut off the threads. I've done all kinds of wild stuff, and that'll work. Not all the time, but at least the laser gets going with that debridement, and it also obviously creates the shrinkage of the soft tissue. So it's a good way to start, but it is expensive.
And I like telling the patient, why am I hearing about this now? Well, because we have this way of treating it that doesn't require the flap and the osseous surgery, and I can actually treat it here in the office now. Question for you, Sam, from Mark in California. Since it seems as though training is so important, what does the company offer in terms of training? Oh, wait, what do you offer in training that does not require training? Oh, it must be, maybe you meant traveling. What do you offer in training that does not require traveling and can involve my staff? It says training twice, but I think they meant traveling, since nobody wants to travel these days.
We have said it before, we'll say it again. Times are changing. Virtual. However, we're dentists. You can't do virtual training on a device you've never touched over Zoom. So what we're doing is we're going to have to bite the bullet, and we're going to go to the office and do the training. Most of the didactic will be virtual, because let's face it, sitting in a room watching slides, that's Zoom. So what we're going to do is make this training very streamlined. All the didactic will be through Zoom, interactive. And then the company will literally go to the office and for a day and a half. And on the first day, hold your hand, look over your shoulder. Possibly on the second day, see you manage patients looking over your shoulder. This will be a trainer that's well-versed in Express or I+ lasers. Because the bottom line is, if you're going to buy that piece of equipment, and Gordon's right on target, you better know how to use it on Monday and start seeing a return on the investment. So that's what we're going to have to do. We are going to do that, actually.
Wow. Okay. Well, that's a great commitment. Travel to them. You don't have to go anywhere. We come to you. That's traditionally not necessarily how it's done, but again, that's good recognition of what's currently going on and doing what's most convenient for the dentist and their practice. We've got time for one last question, and Gordon, I'm going to answer it for you. It's from Radhika, and it says, where can I sign up for Gordon's course that's coming up this Saturday on 50 tips to get you back into practice? The answer, Radhika, is pccdental.com. Did I get that right, Gordon? What's that?
P like Paul, C like Charlie. PCCdental.com.
Or PCC like Pasadena City College, as we like to say here in Southern California. So Gordon, I'd like to thank you for taking your time out of your insanely busy schedule. I've chased you around before. Gordon doesn't eat lunch. He goes and sees a patient. If he's teaching a 2-day course while the attendees are eating lunch, he goes and seats a crown. It's insane. I don't know how he does so much with such little food. He is the Energizer Bunny, and he's been my mentor forever. Gordon, thank you so much for sharing your time today.
Thank you, and thanks Sam. Sam is educating about lasers like nobody else has in the past, and in a pragmatic mode. So we appreciate that, Sam.
Thank you.
Yeah, Sam, pragmatic and periodontist don't often go in the same sentence together, but I think that's a compliment that Gordon is paying you. And I love this idea that you presented of this buy now, pay later, and get a rebate. I would have been okay with just buy now and pay later, but to get a rebate is nice too. So Sam, thank you for taking the time to share your information with us. And I'd personally like to give a big thank you to Biolase for organizing and hosting this event. You know, these days, it's easy to feel like you're alone on an island. So it's wonderful to have this type of connection and be able to share strategies that can be helpful for each other in our practices. And with that, I'd like to turn it back over to the man who introduced me to everything from pineapple martinis to custom leather phone cases, Mr. David Rodriguez.
Oh, that's very kind of you, Dr. Detola, and thank you, of course, for being such a great moderator today, and a warm thank you as well to Drs. Christensen and Lau. We certainly appreciate their time.